As we all know, heart disease and cancer are leading causes of death in the United States and globally. These diseases are usually detected late, after a heart attack or after cancer has metastasized, and early detection and treatment would save countless lives. Both heart disease and cancer have asymptomatic precursor lesions that manifest long before a fatal event. For heart attack, this precursor lesion is the so-called vulnerable plaque, and this is a fatty buildup in the coronary arteries that is comprised of a necrotic lipid core with an overlying collagen-rich or thin fibrous cap. Now, this cap is so thin because macrophages that cause this large lipid core secrete enzymes that degrade the cap, and ultimately that cap can rupture and expose the lipid core to the blood, creating a clot which blocks blood flow to the downstream heart muscle. For esophageal cancer, the precursor lesion is Barrett's esophagus, which is a change in the normal esophageal lining to lining that has cells that are like the intestine. And these cells can undergo genetic mutations, forming dysplasia, and as that dysplasia increases in severity, it can lead to invasive cancer. Identification of these precursor lesions typically involves removal of tissue, processing and inspection under a microscope by a pathologist, and it is very challenging and costly to do systematically in large populations, and therefore these diseases are typically detected in advanced stages. To detect the vulnerable plaque, we developed this OCT catheter. OCT is a cross-sectional imaging technology. And when we put this catheter in the coronary arteries and pull it back, we get these very high-resolution cross-sectional images as seen in the movie above, which can be rendered in 3D as shown in the movie below. And OCT, both in 2 and 3D, is very capable of identifying the structure of the vulnerable plaque. But these precursor lesions are prevalent in the general population, and only about 10% of vulnerable plaques identified by OCT actually go on to cause a coronary event. So to address this problem and get more precision with respect to determination of high-risk vulnerable plaque, we've combined fluorescence imaging with OCT. And we've used this to first look at near-infrared autofluorescence that's elevated in the highest risk vulnerable plaques. And this autofluorescence signature comes from intraplaque hemorrhage and oxidative stress, both mechanisms that cause plaques to progress to an event faster. And you can see in this image that where the plaque is ruptured and a clot has formed, there's a very high near-out signal. Canon has now developed a commercial fluorescence OCT imaging system and catheter, and a first-in-human clinical study is underway to understand the progression risk for these near-AF positive lesions. And this is a great example of MGB collaborating with industry to bring impactful technologies to the clinic. In the future, we're going to be using targeted agents that detect inflammatory activity and inject them in the bloodstream so they'll localize to the highest risk vulnerable plaques, and we can detect them with a very high positive predictive value. For Barrett's esophagus, we have developed something called an OCT tethered capsule endomicroscope for screening for Barrett's. And this is a capsule on a string that you can swallow. Once it's swallowed, it grabs cross-sectional images of the entire esophagus, and you can distinguish the normal esophagus from Barrett's because the normal has a layered structure, and Barrett's, you lose that layered structure and you have replacement of the surface of the esophagus with these intestinal-like cells. When you render it in 3D, you can see that the normal esophagus is flat and smooth and Barrett's is rough. The problems with this is that if we were to screen everybody with this capsule, we would find that there's 15 to 30 million people with Barrett's in the United States, which would cost a tremendous amount of money if we were to follow up all of those patients, yet only 1% of those with Barrett's will ever develop cancer in their lifetimes. So we've combined OCT and fluorescence in a capsule to improve our predictive capacity for high-risk Barrett's esophagus. So the way this works is that you swallow methylene blue with agave nectar in a slurry. The subject swallows the capsule. We turn the light on when it's in the esophagus to look at the fluorescence. And then we get a pullback that contains microscopic images shown in grayscale of the esophagus, as well as the fluorescence in the color ring around the grayscale image. So the way this works is that OCT can accurately detect Barrett's. Low-risk Barrett's takes up the methylene blue stain and has a high fluorescence signal, but high-risk Barrett's does not take up the methylene blue stain and has a low fluorescence signal. So when we see Barrett's by OCT and low fluorescence with our fluorescence imaging modality, we know we have high-risk Barrett's. And in the future, we're going to explore targeted fluorophores that look at byproducts of genetic mutations of Barrett's to further increase our predictive capacity of this technology for determining which patients have the highest risk Barrett's that will develop into cancer in the future. So the potential impact of this is high because by combining fluorescence and OCT, we can offer more precise and personalized care. Most heart disease and cancer mortality arises from late detection. There are precursor lesions, but the problem is that a very few of these precursor lesions actually cause a fatal event. But combined OCT and fluorescence imaging can identify the most progression-prone precursor lesions with sufficient precision to initiate curative therapy earlier while focusing our resources on the most at-risk patients. And these are minimally invasive devices that are suitable for broad screening. When we were looking at our roadmap right now for coronary disease and detection of vulnerable plaque, we're doing near-AF studies, and we're also looking at targeted agents in first-in-human studies with the Canon system. Once we've done that, though, we're going to combine this with therapy so that we can treat the highest risk vulnerable plaques. And then we're going to do outcome studies to show that coronary events has decreased by looking at these high-risk vulnerable plaques and then treating them. And if those outcome studies are positive, it will result in a change in medical guidelines. Similarly, with esophageal cancer, we're looking at first-in-human studies with methylene blue and targeted agents. We're looking to form a new company and seek collaborations in doing that. Again, we're combining it with therapy, doing outcome studies to show a decrease in cancer death, again, with a change in medical guidelines. So to conclude, by combining OCT microstructural imaging with fluorescence molecular imaging, we are pioneering a transformative new approach to early disease detection by enabling clinicians to identify and treat these precursor lesions before they progress, ultimately saving lives and reducing the global burden of heart disease and cancer. Thank you.